I'll introduce myself. I'm Jesse. I'm the senior peer worker for the Safe Haven team and Spot team in Griffith and Wagga. And I'm sure when Loz gets up here, she'll introduce herself, hopefully. So I know everyone's having acknowledgements today, so I won't go through the acknowledgement, but we would like to acknowledge the custodians of the land that we're on today, and also like to acknowledge lived experience in this room. So we'll kick off with SPOT. So we all use acronyms in health. So SPOT stands for the Suicide Prevention Outreach Team. It was part of the Premier's priorities to reduce suicide by 2030. By 2023 actually, by 20%. So Murrumbidgee is quite unique. As you can see, Murrumbidgee is a huge geographical mass, 125,000 square kilometres, which is quite huge, when Sydney district is about 127 kilometres squared. So with that, SPOT is only virtual. So we don't do outreach like a lot of the SPOT teams in the cities do. That's only because we wouldn't be able to see as many people as what we can. So we average about over 100 referrals a month for SPOT. So that's referrals. So that's not contacts. So throughout the week, although we have we'll contact people Friday throughout Monday. SPOT is co-located with Safe Haven, which is quite and unique as well. So we have clinicians located in the SPOT and Safe Haven building that we work quite closely together. So on the SPOT calls, clinicians and peer workers both work collaboratively to support the person on the other side of the line, sorry. So we are operated Thursday through to Monday, 2 p.m. to 9 p.m. So we really do try and cover that area when traditional services aren't open. So when people are in need over that period, it used to only be really ED, which isn't sometimes the best place for some people. So we really try and be open for those people that need it. And again, so how SPOT calls are done. SPOT calls are done virtually through My Virtual Care, and it is a virtual service, so we do try and encourage people to use the face-to-face component of My Virtual Care, because we find that when we have that personal connection, we get a lot more benefit, and the person hopefully gets a lot more benefit when they can actually see the people they're talking to. But we also provide traditional phone calls for people that may not have access to the technology or may just wish to speak over the phone. The calls are a collaborative approach between peer worker and clinician, and it is a collaboration. So the clinician's not just there to do a risk assessment, they are part of the call and they're a valuable part of what we do. And obviously the clinicians are there to do the risk assessment and any of the clinical assessments, but they also share some of their lived experience to build the rapport. And we also work closely with a lot of other services as well, which we'll go into. As I mentioned before, it's part of the 47 million funding initiative to decrease suicide that the New South Wales government committed to. And it's part of 3 initiatives towards zero suicide, which is zero suicides in care, alternative to ED, which is a safe haven, and the suicide prevention outreach team, which we spoke about today. So with that, I'll hand over to Loz to speak about Safe Haven.
Thanks, mate. Bit short. Okay, I'm Lauren, one of the peer workers at Safe Haven in Wagga. We also have our safe haven in Griffith as well. I'm going to talk a little bit about what we do when people come and visit our service. So, I'm trying to see. Okay, so the safe haven, it's a friendly alternative to the emergency department, and it's set up in like a lounge style area. When people come, they're usually greeted by a peer worker, and they're offered a warm or cold beverage, and they have the option of whether or not they would like to sit and have a talk with a peer worker, or if they would like to do some sort of mindfulness activity, or just whatever they need, really, when they're coming in as crisis. So, everything is, we offer it's a non-clinical environment, it's compassionate, and we offer confidential care. So it's a really, really safe space for people. There's no wrong door. Everybody is welcome, including under the age of 16, as long as that there is a parent or guardian of consent. And yeah, there are 19 safe havens across New South Wales. Okay, so what our consumers can expect. Safe havens, well, it's a place where people can come where they don't have to feel like they don't feel judged, and it's where they can talk openly with a peer worker who have had similar emotions that what I've probably experienced or what Jesse's probably experienced, and we kind of sit with the person and kind of just talk their way through what's going on from then. Okay, so what we've learned and where to from here. So to continually improve, always open to feedback, consumer rounding, so we have that at least each month. We use our yes surveys to find out if what we're producing to people is working, and co-reflect practice. So I guess we're open to a bit of questions around this. Does anybody go for it?
So my question would be, you said that you provide confidential support. Do you still do progress notes or like any kind of documentation, even if they are confidential, and how do you do that?
Do you want me to answer it?
Yeah. Yeah, so we still collect data, I guess, but it is up to the person. We always ask the person, and so far we've had no one say no, they wouldn't like to give that. But yeah, it's good for us being a new service to collect data and the demographics of who's attending, and also for them, a lot of the people that come to our service are already linked in with other services, particularly community mental health. So it's good to have that continuity of care, and it's good for the clinician to say, well, they're using this service. How do we utilise this service more? So yeah, there's no mandate to say they have to give information, but we do ask for it, and people are usually pretty happy to provide it. Yeah. Nice.
So if a young person comes in and has a chat, greeted by a peer worker, they calm down and they're okay, do they still need to see a clinician and get assessed at the safe haven? They could just leave and that's it.
Yep.
Wonderful.
Yeah, so around safety, which is obviously our number one priority, the peer worker, it's obviously two staffed, and the clinician comes in usually when whether or not we determine that person is at risk. So if they're not engaging, if they're future focused, if they're willing to safety plan with us and de-escalate with us, then usually that's not when we need a clinician. There are other ways that we get the clinician involved, and they come in and have a really good conversation with the person. And there have been at times, the thing about where we are located is that if somebody does need to go to ED, that's where us peer workers come in and we contact the triage, give a handover at triage, because I know from my experience, going up to that window and saying, hey, I'm suicidal, is the most mortifying thing to me. So if we can get ahead of that and let them know that we're coming, then we can help make that transition to care a lot easier for the person, and it's more trauma-informed. Sorry, I couldn't hear.
Oh, sorry, I was just wondering if you would classify that as like assessing risk, just deciding whether a clinician gets involved or not from your like model of care point of view and stuff.
So yeah, it's definitely person-centred. So we would never, I guess, we obviously as peer workers, you know, or just as people can say, okay, if this person's not safety planning or they're quite at risk, but it's always with the person and say, hey, look, and using our values of peer workers and role modelling that, hey, like I'm feeling really uncomfortable now. I'm really worried about your safety, and I would really love to get a clinician in here to maybe have a chat to you because I'm worried that if you leave here that you may be in danger. And again, I think it comes down to building that relationship and that rapport with that person, and usually I don't think there's been a time when someone said they don't want a clinician. They're usually like, okay, look, I'll have a clinician. But again, it's person-centred, what that person wants or needs. And obviously we can say, look, I think you need a risk assessment by a clinician. And they have every right to say, no, I don't want that. And clinicians are really the last port of call for us. And what we found that in the 2 years that we've been open, people have been able to regulate their own emotions and keep themselves safe on their own, given a safe environment. So it's very rare that clinicians are involved, but yeah, 100%. It's not up to us to assess that risk, but work collaboratively with that person they know themselves the best. So awesome question. Thanks, Anna.
Hi. I have two questions. I'm going to say them both and then...
Sorry.
Okay. All right, first question. I was wondering if you could give a rundown of the layout of the Safe Haven house and how many like individual rooms and stuff are. And my second question is how much EMR documentation is involved with the SPOT service and also the Safe Haven service,
Yep.
if at all.
Happy to answer the first if you want the second. Yep.
You should do the documentation.
So the Safe Haven layout, I don't know whether any of these pictures are any good, but it is a lounge setting. So I know every district will be different depending on their location, the building layout itself, their model of care. So our Safe Haven isn't the best Safe Haven, unfortunately, in the sense that it's very wide, open, and there isn't too many quiet spaces for people. There is a sensory room, but it is quite small for only one or two people to be in there comfortably. So we've had, at any one time, 3-4 people. We've had 5 people at one time, which is very rare for us to get 5 people in at the exact same time. It's usually spread out. So the layout is a bit of an issue, but again, we try and make it person-centred. People have the options to stay and be in that environment, and we support them the best we can. Or we offer people to come back at another time if they're in a place to do that, if they're not too heightened. But yeah, unfortunately, because of the layout of the building, offering those really quiet rooms aren't possible. And that has been an issue from the very start. But I know some Safe Havens are in pop-up tents and yeah, someone's nodding.
Thank you, guys.
You're on, Shelley.